I think Gerandi, yeah, meeting is being recorded. Gerandi, let's go ahead and bring up the slides and we can get started. Do we need to do introductions, or are we all know each other? I can see you all on the screen. Okay. All right, let's go to the next slide. All right, so let me review our plan for today. We can check in on the notes from our first meeting. There were a couple of questions that you all had asked, and I have some follow-up information to share back. One of those requests was to talk a little bit about the definition of health equity that OHA and the Health Policy Board uses, and what does that mean for this work? So we'll spend some time talking about that. And then I think it's mostly going to be a really open-ended discussion. There were a bunch of questions from last month that we didn't quite get into, and we wanted a little more information before we dug in. So I think we'll tee that up and then just see where our conversation goes today. Does that all sound okay? Anything specific or anything people want to add? Okay. Oh, and also I sent this out in the email last week, but there were some other resources that I found that I shared that might have been helpful in sort of that recommended reading section. So I don't know if folks have had a chance to browse through that, but that might help inform the discussion, or there might be some things in there that we want to pull through. Okay, let's go ahead to the next section then. All right, first up, meeting notes from meeting number 1, pretty high level summary, just trying to capture some of the key themes, but are there any questions or any edits from that meeting summary?
They look good to me.
Look good to me as well.
Great. Okay. Then we will keep them as is. Okay, so first follow-up question was, are there consultants that are specifically working on health equity and cost containment, or health equity and cost growth? So there were sort of 2 tracks to this question. The first was, have the other states, the other cost growth target states, done anything in this area, or have they engaged any consultants? We did some asking, reached out to some colleagues, and as far as we can tell, no other cost growth target states have brought on a consultant in this area specifically. And then the second track was, are there other options? So I think a couple folks had mentioned ideas or names last month. So Robert Wood Johnson, a couple of other potential organizations. So yes, I think there are some folks who are working in this space or thinking in this space that may be open to consulting. Some of this is in the recommended reading materials that we sent out, but my take of the recommended reading is that most of the work in this area is really high level, and possibly, we have already pushed the conversation a little further. Some of the recommended reading materials around health equity and cost containment just say, you should consider health equity, check. And so this level of detail and this level of maybe specific strategies and specific activities that we're pushing to, I don't know that anybody else has gotten that far. It's really high level from my scan. Yeah, Michael, I was afraid of that too. And that's sort of what I found. I certainly, I might have missed things, not necessarily comprehensive. I think we could do a little bit more work to follow up with some of the other authors of some of the other, some of these papers and articles that we found, but it's really high level. The white paper from Milbank that we looked at last month that had the sort of specific strategies for stratifying your data analysis, ensuring a diverse and representative advisory body, that's as detailed as it got that I could find. So we might be in uncharted waters. I don't know if anyone has any reactions or other ideas for where we could poke at this, but I really don't know that there's much out there that we could draw on at this point.
That's kind of the sense I've gotten talking with people, is like, it seems like there's been a lot of thought around health equity and then maybe around cost sustainability, but how those intersect, I don't know that there's been a lot to try to bring those together.
Yeah, well, I guess that means we get to be trailblazers in this area, and maybe some of where we go and what we come up with can help inform others, or at least, spark some thoughts or additional discussion in this specific space. But yeah, it seems really undeveloped so far.
For what it's worth, whenever this group reports back to the full committee, I think that's definitely the main theme or point that I want us to highlight, is that, we looked and this hasn't been done before. And so there's no path forward. And so we can't wait around for someone else to tell us how to do it. We're going to have to try, and we're going to have to be open to making mistakes and missteps. Like, yeah, because we got to remove the fear from the group's, because we can't wait around and we can't be too afraid to make mistakes that we don't do anything. So that just has to be, I think, a theme that really rises to the top when we report back.
Agreed. Love that. Okay, let's go to the second follow-up question. Next slide, please, Gerondi. The other question that you asked was, how, if at all, is health equity and cost containment discussed or talked about or framed in Oregon's Medicaid 1115 Medicaid waiver? I don't remember who asked this or if there was something specific that you thought might be in there, but did some reading. And while the 1115 waiver is very equity centered throughout, woven through, there's a lot in there, but really when it comes to cost, the waiver is focused on budget neutrality. So how much is Oregon's Medicaid waiver, Medicaid demonstration costing the federal government? And there's a lot about budget neutrality, but that's really not cost growth and cost containment in the way that we're thinking about it. So there are some general references in the waiver about the triple aim. So better access, better quality, lower cost. There's some references to cost-effective services like the health-related social needs and their impact on equity, but not thinking about that as a cost containment strategy or about this specific initiative or the specific intersection itself. And then there's some reference to using value-based payment arrangements to manage cost growth, but really nothing about value-based payment and equity. So sort of a sprinkling, but nothing specific that I could find that I think people were maybe hoping for there. So a similar theme, maybe nothing to rely on. Can't wait for anyone to tell us what to do, but we did check, and I don't know if anyone was thinking about something else specific that might have been in the waiver.
No, I think maybe I asked that question, and I just think it's good for us to understand, what's in the waiver, and as that's driving a lot of policy right now. But yeah, it's interesting, similar to how there hasn't been necessarily a very intentional link between cost sustainability and equity. I think the same is maybe true also with value-based pay and health equity, although I think there are now attempts to try to overlay an equity lens, on that, but the land construct framework really doesn't talk about equity. So you could get all the way over to being at the high end of value-based pay arrangements and really not have any regard to how that impacts equity. And so I think this is, again, kind of we have to be more intentional at how we link those, and if we're seeing it through an equity lens.
Yeah, I mean, I think to me, that's just kind of reinforcement of how equity has been factored in over the years, right? Where it's more of an afterthought. And I know we're trying to shift that in Oregon by being more proactive. So the other thing related to the waiver, I know I mentioned last time, is not necessarily specific to this question of what's in the waiver around health equity and cost containment, but the point that, we developed and piloted a health equity impact assessment, both a retrospective process, but then also developed a prospective process that is the OHA now has and is trying to figure out how to use and spread, that either helps you plan, develop a new policy, concept, program, or rule from the start with kind of like focused on community engagement and health equity and connected to that health equity definition, or there's a retrospective that helps you assess a program, a concept, or whatever for its ability to advance health equity. And so it's potentially something that we could look at using for any recommendations that this committee comes up around healthcare costs containment, either in terms of how we develop those recommendations and how we evaluate the recommendations to determine its impact on health equity. Was just something that I think for us to keep in mind. I don't necessarily know if it's like just we can take it and apply it as is, but just something for us to think about and know.
Yeah, I think that tool is a really great piece to keep as part of this. And whether it's something that we potentially do as a work group, I think that's an option. We could say we want to do a prospective look at the potential cost growth mitigation strategies that are currently on the table, maybe around pharmacy, or this could be more general recommendations as the committee should do this for any time a strategy is being considered, or both. I don't know that I would rule out both. I think we could pilot test some of that maybe. Okay, anything else on those follow-up questions? All right, let's go to the next slide then. Okay, one more. So we wanted to reground in the health equity definition that the Health Authority and the Oregon Health Policy Board have adopted. This is something that guides all of the work of the committees of the board and agencies. So this is directly relevant to the cost growth target work as well. So I think probably everybody has seen this definition, but just in case you haven't, here it is on the slide. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So I think where we left the conversation last month was, and this might feed right into just our broader discussion of, as we think about the work of the Cost Growth Target Program, the Cost Growth Target Advisory Committee, how does this health equity definition relate and provide direction for that work? Is it more of, are we more in the neutral, not causing harm space? Are we more in the proactive, actively rectifying injustices? I'm going to stop talking and see where you all want to go with this, but I think we left it very open-ended last month. So
I guess from my perspective, I'd like for us to be more proactive than just merely passive and sort of looking at the no harm, I mean, that should be the bare minimum, but it seems that if we're really going to advance health equity, we can't just allow the status quo kind of, because that's already reinforcing the historical inequities that may exist. And if we're really going to advance health equity, there has to be some effort, some proactive role to play in policy and how we're trying to address this. So I think if we just kind of are sitting back and seeing how the system is going to behave without really, trying to guide it, towards these objectives, then we'll continue to get the same disparities that we have seen, over the years.
Yeah, I agree with all of that. And really, I kind of feel like there really isn't at the end of the day, in my mind, a do no harm approach. Like if we, what that means, what that means to me is that, things will continue, as Gil was saying, as they have been, and the way that things have been is actively harming people. So our failing to take an active approach to try to address the injustices that are continuing in the system as it exists is, not is the bare minimum, I think.
Yeah, and I think my comment is just pretty straightforward, right? We got to understand the why behind why this is happening, right? In order for us to solve something, we might need to understand why these disparities exist, right? So, for example, being in finance world, it is finance reimbursements and policies and structures aid these type of behaviors, right? Where your reimbursements are higher in areas where commercial markets, right, and ability to pay. And so, being able to be challenged in an environment financially challenged, you will take actions where you will, kind of further go into areas there where you further kind of go backwards if you don't really, address how the financials or the money flows. And in today's world, people go after, right, the finances, whether it's your profit or non-profit, you got to spend less than what you get. And with narrow, thin razor margins, people will go to areas where reimbursement or there is less, more potential to get better reimbursement. So I think there is something that we need to tie some of our, if we do come up with something, to tie finances to it, to incent this type of, to incent that parity amongst these type of things. So that's kind of my thinking here.
Yeah, just looking at an example, we think sometimes the value-based pay is going to be a tool to help us address costs, and sustainable costs. And I think that's true. However, if we just look at VBP without the equity lens, then we have the potential to exacerbate the disparities in health inequities, because on the face of it, a VBP approach could mean, well, I want to get as many of the healthy folks, and avoid adverse selection so that, my quality indicators look good, my cost and complexity, are good, so I can reap more of the shared savings and things. And so then what about, the more complex or populations, if we don't look at it from a racial, ethnic, or demographic, breakdown, then we have potentially to again make the current situation even worse. So that's just one example, I think, in terms of when we're thinking about cost, sustainability, and equity, how do we, it's more than just do no harm, because that would be just, well, the land, that's going to take us to where we need to go in terms of moving us all the way to these shared accountability in terms of downside risk and all that. But if we're not actively also asking the questions about what is this doing, for specific populations, then we might miss that.
Yeah, two comments I wanted to make, separate from what everyone said, which I agree with everything so far. I'm not going to restate that, but I was on the Health Equity Committee when we developed this, and the thing that I think is helpful that our intention is that the last part of this definition would help us figure out a way to somehow translate this vision into action and or measure something by including that kind of equitable distribution or redistribution of power and resources, and are recognizing, reconciling, or rectifying, right? So that kind of part that Hridesh was talking about, like, unless you understand what's driving some of these disparities, like that's kind of part of that recognizing, and then you reconcile that and you rectify, like that requires some kind of action. And same with the, at the end of the day, our resources and power, have they been redistributed or distributed equitably in a way? And I think I've also been part of that waiver project was trying to align the tool with this definition. And so, a large part of that prospective and retrospective is asking, do these proposed policies or procedures or whatever result in a redistribution or distribution of resources and power? How does it recognize, rectify, and so I guess I would like to see us, as we figure out what equity looks like in terms of healthcare cost growth containment, also try to align with these pieces as evidence or action. And then the second thing I wanted to say is that I think one of the things we learned in the waiver when we did it is that not every single policy is going to have a direct, oh, this is advancing health equity. And so that led us to, well, should it even be something that we're promoting? But there was this recognition that some of the policies, while it doesn't directly impact health equity, creates a mechanism or supports further change that would do that. It kind of paves the way for other health equity. And so that's also something for us to think about is, not everything may we be able to say will directly impact health equity, but it might create an infrastructure or system where money can flow in a certain way that it would support health equity or overcome the barrier. So.
Thank you for that, Michael. I think both of those points are really great. I'm almost starting to hear this, like what could be a potential framework or like almost a draft shell for what the work group recommendations could be, because I think we're talking about a bunch of different things and it's starting to maybe come into focus a little bit for me. So I think there's the recommendations related to how does the advisory committee make its decisions, which could be about which policies are we recommending, do these policies go through this health equity impact assessment before they're recommended, all of that. There could be some very specific tools and criteria brought to that part of the discussion. Then there could be potentially another layer is how is the program operating? So that's what is the state doing? What data are we collecting? What are we reporting on? Where are we bringing transparency and including? And that's the sort of recognizing component, maybe helping understand the why. And then maybe a third layer is what are payers and provider organizations who are subject to the cost growth target doing and recommendations for them. So it's possible that maybe our conversation sort of has these three different tracks and some things go in one spot and not the other. I don't know if that makes sense, but I think I'm hearing a lot of what do we do as the committee and the work group of the committee? What does the state and the program do? And then also what does the system need to do? And maybe that's where some of the VBP conversations are. And there could be, going back to that VBP recommendation, there is the value-based payment compact work group. And one of the questions that will be coming up this year, I think later this year, is we only set value-based payment compact targets until 2024. Do we need to reset those targets and extend that work? And is that an opportunity to include more of the equity framing, the equity impact assessment? So I think that sort of lives in that committee space, and how do we set direction and recommendation? How does that, as sort of a maybe very high level drafty framework to start organizing our thinking, make sense to you all?
I like that framework. And then, there's, I was kind of looking through some of the references that you gave us, for what some other states are doing, and those might, ideas like that might fall under some of those columns, in your framework, as we, because I think there's some interesting things that folks are doing around this. Like in Maryland, where they're kind of looking at that applying certain chronic care management payments, to populations where with known disparities, and so that may, you know, may live somewhere in kind of an example of to help guide VBP work as well as this cost sustainability work.
Yeah, I need to think more, and I almost want to see a visual representation of those categories, because I'm a very visual person, so, but I like it so far. And I think the other part of the framework that I hear coming from this work group to the full committee is saying we have this overarching value or approach that supports Oregon's goal to eliminate health inequities by 2030 and rest on this health equity definition, right? That we pursue things that actively, you know, in healthcare cost growth, we pursue things that actively advance health equity or set us up, create a system that does, and that this idea of neutral, or like, we're not going to be a, you know, neutral is fine kind of committee. And I feel like that's what I heard from this work group pretty unanimously, that I think is a key part of what we would present.
Greg, Hardesh, thoughts, reactions?
No, I support it. I think you know, just starting somewhere, you know, to put something like a sort of visual or starting somewhere, and then we can always build on that. But yeah, I support it.
Yep, me too. Yeah, and I echo everything Michael just said too.
Yeah, so it really is what I'm hearing, and I'm also a very, like, I want everything to be in a matrix and very organized. So like, if I'm pushing too fast or too hard onto like, here's a framework, like, and we need more exploration, please rein me back in. But I think I really like what Michael was saying about there's the overarching goal, there's the overarching definition, there's the sort of the stacked umbrellas of then how does this guide the committee's work, the program work, and the payer and provider work. And there might be specific strategies or specific tools that are appropriate for each of those layers. So we could say, before the advisory committee recommends any cost containment strategy, we need to conduct a health equity impact assessment using this tool or something similar. And that needs to be part of the committee process. Like, that seems like a very sort of tangible, applicable thing that could happen as part of the committee's work. There could be other recommendations or other specific tools that we'd want to weave in. And it feels like all of this could come together into this is our approach. And as a work group, we might have other questions. So like, what are some other ideas or strategies? But that's not necessarily the same thing as the approach for how we bring health equity and these considerations into the cost containment body of work. Does that even make sense as a distinction? I'm going to take your silence as yes. I think I briefly saw heads nodding, but I think like some of these pieces, like a very specific, value-based payment arrangement is a strategy. But I don't know that we necessarily want to come out of this work group, and maybe we do, maybe we don't, of here are 3 strategies that we think Oregon should pursue. It might be more of these conversations are happening in lots of spaces with the committee, with payers and providers, with the state. And some of the strategies or ideas that we might come up with, or ideas that we might identify from other states, feed into some of those places. But ultimately, we have this approach for how these considerations and these conversations could happen.
Yeah, I agree with that. I guess what I'm trying to wrestle with is how the cost containment or strategies don't currently reference anything right about health equity or disparities, you know, among populations or anything. It doesn't even ask for that level of data, you know, in evaluating the costs, performance, you know, of these different systems. And what would it look like if we also had some and probably you know, our data collection's not at this level to be able to do this, but really to look at, you know, the costs growth, but then by racial, ethnic, you know, categories, or you know, demographics, and more of a because, you know, we just lump all cost, you know, as a whole, you know, as a whole population, and we don't really look at how that plays out, you know, with specific populations. So it's like the basic framework of our cost sustainability work doesn't really have a way to integrate that view of it. And maybe that's our task, you know, as a health equity committee, is how do we insert that perspective on this? But understanding, I'm not, I don't want to minimize just the difficulty of, you know, getting systems to collect that kind of information, because I know it's even hard for us as a federally qualified health center, and yet that's kind of what our charge is. We do that on, you know, on a routine basis, but that's not necessarily the case across all systems.
Yeah, and for me, this really fits well together, and I'm kind of tied back to my emerging framework. So if we think about like that second bucket of things that the state and the cost growth target program are doing, I think providing that stratification in the reporting and making that available for discussion and public facing and identifying more of those is a very reasonable recommendation. And I think it makes a lot of sense and is aligned with what we're doing. It's not currently part of the data collection that the cost growth target program is collecting from payers. We're not measuring sort of individual patient costs in that way. That said, we can use our all payer claims database and we can do a whole bunch of demographic stratification. The race ethnicity data in the all payer claims database is very imperfect. It is not REAL-D compliant. It uses the federal OMB categories. There's a bunch of missing data. There's work to improve that. That's on an ongoing basis, but we can do a lot for population level identification using some of the other demographic factors. This is something that I want to say Connecticut is actually doing a little bit. They did some cost analysis by zip code and looked at differences, sort of geographic pockets, and overlaid that with a poverty map. So they were sort of looking at income and socioeconomic status. We can do a lot with age, with a couple of other demographic factors. So that is something that is a very reasonable place to push the program and saying this is an expectation and this data should be available.
Yeah, I think that makes sense. We gotta, we gotta get data to really inform us on, so we can really understand where, what the opportunities are. And like I said, start with a framework. Just pick one from here, the very first one, race, right? Race, how many, if you can get data on race disparities, on how many, what's the percent of those populations that have a physician assigned to manage their care, right? And see if there's a disparity in percent of people by race who actually have physicians managing their care, and see if there's a disparity. I think those types of data are very informative. And zip code data, there's a lot of focus on zip codes now. It's management by zip code is what we at the health plan are doing. We find that the best way you can understand a person is no longer by anything but their zip code they live in kind of determines who they're going to be and how much healthcare is going to cost. So I think that data we gotta focus on getting some of those qualitative data, right? Not necessarily claims based, but qualitative data that we need, that will inform us, that will probably help us understand some root causes on where to focus on.
So it seems to me like there are significant portions of like the cost growth and equity problem that there's been a fair amount of research done on like spending on social determinants of health that we know, or I believe that the research strongly suggests that spending on social determinants of health, both I guess referring back to the 1115 waiver slide, both has a positive impact on health equity that's going to tend to primarily benefit folks who have been disadvantaged by the current system, and also is very cost effective, at the very least budget neutral, and probably reduces healthcare spending costs over time. So it seems like there are also items like that for which we already kind of seem to have enough to be able to make some use to make decisions with regard to how we might structure how the cost growth target objective is met, and things that can be done to reduce healthcare costs that are in line with equity and don't require a data collection piece to move forward. So it seems to me like at the same time as it's important to collect this data so we can see what we can learn from it, there are things that we could perhaps recommend be incorporated before we collect any additional data as well.
Yeah, I hear that, and I like the idea. Like that sounds to me like one strategy where we have some data or understanding that helps both achieve cost growth containment and advance equity. So I think that's something we should definitely keep in our mindset. But the thing that when I want to go back to something that Gil was saying at the start of this part of the conversation, because it seemed to be a very similar question that I've been trying to articulate, and I haven't done well over the first couple of meetings, which is, I think there's a bigger question that maybe this work group tackles around what is even the connection, or how does it work together, the idea of cost growth containment as a concept and as a priority, and health equity, and understanding in which ways they kind of naturally align and which ways they might actually get in each other's way, so that we know what we need to mitigate and what we need to amplify. And I say that because it sounds like maybe a theoretical conversation, but I had the same question like with some quality improvement initiatives, because I know there's a large focus on quality improvement, and part of that is like standardize and streamline and create efficient systems so people kind of make sure people get everything they need, and it saves money. And it in some ways was very counterintuitive to providing culturally responsive care, right? That's tailored to this idea that not everyone can have the same approach. And so there was kind of an inherent values conflict almost in that, and without unpacking that conflict and understanding, it was hard to kind of advance quality improvement while also advancing equity. And I feel that's kind of a similar thing that at least I'm asking myself, and I don't know enough about healthcare cost growth containment, which maybe I shouldn't say that because I'm a member of this committee, but I haven't learned enough yet about to know exactly in what ways it does kind of naturally lend to advancing equity, and what ways it might actually be counterproductive, and we need to manage or mitigate that. And that might be a conversation that we need to have.
I think that is the conversation we should have as this group. And I think this might actually be our next, so Michael, when you just said, again, because I'm framework oriented, I kind of feel like we need a logic model, and it's actually two logic models. I think there's the at the high level, the purpose of having a cost growth target program and what are the intersections there with health equity. So for example, one risk, and I'm spitballing all of this, but one risk is the cost growth target program is intended to slow the rate of cost growth. It uses it bakes in the existing baseline. So if there are already disparities in how much people are paying for care or how much those costs are affecting different populations, which we know there are many disparities there, we're just looking at the rate of growth year over year. We're not looking at any changes within group or changes in groups relative to each other. So a con of the way the program is structured is that we're just baking that in and ignoring it. Then I think there's where are the intersections at the payer and provider level. As payers and providers take action to meet the cost growth target, where are the intersections? And that's for me where that parallel with quality improvement comes in. So for example, a con or a risk is if a payer says, I want to have a healthier population because they will cost less and I'm going to selectively drop members, that is a negative. That is a risk that will worsen disparities, possibly inequitably distributed some of that risk in the population. So I think I'd like to map this out a little bit, and this might be like, some whiteboarding, and I could put something on paper that we can react to next month or next meeting. But I think it really is at these two levels. There's sort of the program and the program intersection, and then there's the payer and provider actions and strategies and that intersection. And we probably want to have discussion and some recommendations, protections, considerations. I don't know what the right thing is, for both levels. Like at the end of the day, we could say I'm about to say this publicly, like the cost growth target program, as it is designed, does it inherently do anything related to health equity? I mean, it's really not everything that we're talking about. We can measure some of the underlying disparities in co-pays and cost sharing and medical bankruptcy due to healthcare costs. Like that's all supplemental, and we can look at that, and there are disparities. The cost growth target program is not designed to fix that. So should it? And we need changes to get there. And then there's also all of the trying to then contain costs in those actions, whether that's value-based payments or other strategies. Does that, I'm seeing heads nodding. Seems like that resonates and that all makes sense. Thoughts about that?
Yeah, I think because the way it's currently structured and from the report or the displays of how we intend to share how people are performing on this cost growth targets, and health equity is not at all a part of that. And I think as you state, it wasn't really intended as the goal, perhaps, is mainly, hey, we want to, bend the cost curve or, help keep our costs within a certain percentage points, and so how are our systems performing against that? And it does seem like that has the attention of systems, and people are thinking about, well, we don't want to show up negatively, on this cost growth report, but it's a very, in a way, blunt instrument, because it doesn't get into, a lot of what you were just describing in terms of what is the impact within certain populations, and maybe there are a lot of those disparities which currently exist. Those are not brought into any of that analysis. It's just, oh, we're below, that's good, or we're above, that's high, that's not good, and that's it's a very kind of crude tool in terms of designing where we want to go totally, as a system. I mean, it's an important part, but there you could argue that there some populations or areas where we want to be way above the cost target, because to address historic inequities, and that but that but how do you represent that? What is that intersection? between that work and the health equity and these other efforts that are going on, like with VBP and stuff, which can be a tool, but also needs to be a tool informed with that equity lens.
Yes, I think yes to everything you said. And I want to make one specific, like connecting the dots, maybe with what Michael was saying earlier about not every policy might be explicitly about health equity, and some might be more about the infrastructure. And I think it is possible, we should talk about this more and, work on the logic model, but I think it is possible that the intent and the way the cost growth target program is designed is to create that infrastructure where we say healthcare costs, if they continue to increase year over year, cause all kinds of problems downstream, and there are disparate impacts on different populations downstream. So the cost growth target program is trying to slow that down. There are a whole bunch of other strategies and more specific places where we do want costs to grow, and places where there might be payer and provider strategies that are more specifically problematic, but at a very high level, the cost growth target program is trying to slow things down to avoid making some of those downstream impacts worse. We don't want to continue to push more people into medical bankruptcy. We don't want to continue more people delaying access to care because of costs. And then we need a whole bunch of other specific things to address some of the other concerns, but that the program itself is really trying to just put the brakes on a little bit. And I liked how, Michael, you said it earlier, that it's creating those conditions, and I think that might be a really good lens to bring to this work at the program level.
Yeah, I'm gonna do a complete shift here maybe, but given where we started this conversation saying there really seems to be nothing out there related to this, that we might be paving the way. I don't know, Sarah, if OHA has access to the resources to have another staff person sit along with this and try to map and document these ideas, these huge questions we're unpacking, the pathway, because depending on where we end up, I could see other states wanting to know how we ended up with whatever we ended up, and what were those big questions, like this idea of saying, like, we had to talk about this big question of, does healthcare cost growth containment and equity even fit? And some of these things, I think if there's a way, instead of waiting till the end and we try to go back and document it, it might be nice for OHA to invest resources to actively map it and document it, with the idea of trying to have a white paper or something that you guys have, so that all this work can be replicated and shared. So.
Yeah, yes. There's a whole bunch in there for me to think about. And I think this almost, I'm going to pivot us a little bit into what do we think the output of this work group should be. And as we've currently suggested to the implementation, or to the advisory committee, we will come back in September with findings, recommendations, something. I'm hearing a couple of things. I'm hearing we could have a white paper that summarizes all of this work and where we land, so that other states could benefit from it. And so also the process is pretty transparent to the rest of the advisory committee. We could have some specific tools, and these tools could be embedded in the white paper or not. That might be the logic model, that might be the different questions to ask at different levels. It might be a philosophical position about how does this all fit together and what do we think this, like, I think I definitely want this work to be transparent, and all of our conversation and wherever we land and the questions we've asked as we get there to be available. So whether that's a white paper or like our recommendation statement back to the advisory committee, whatever, like, yes, I think OHA will support putting that together. Michael, I don't know if you're suggesting something sort of above and beyond that, or if there are other things that we want. I mean, if we come out of this with, these are the big questions we asked, here's a working framework, here are 3 specific things we think the advisory committee should do going forward, that's going to be a really solid body of work.
Yeah, I think I like all of that, and I like the things that you listed as products, and the white paper could be it. And when I was meaning kind of a mapping, it's almost like just developing a case study of this work group and the process that leads up to that. And I say that because I was when we were talking, I was recalling Another consultant from somewhere on the East Coast reached out to Oregon to talk about the health equity impact assessment on the waiver and tools and process, because they're trying to figure out what to do there. And as a part of that, I talked to them for like 30 minutes, and all the questions they were asking, I was like, oh yeah, we should, like we should have captured that or paid more attention to it when we were doing it, instead of trying to now recall it all, because I'm sure
Got
we
it.
missed some of
Got
that.
it.
And
Okay.
so it was the idea of, if there's someone not, you're like putting your energy to like keep us together, to tie our comments together, to like, you're providing all that framework and support. And I don't think, it's fair to even ask you to think about also observing kind of from an external perspective and documenting this group, because it's going to be, I think it's going to be a pretty groundbreaking product that could be developed potentially.
Yeah, that makes sense. Thank you for that distinction. I want to take this to our consultants that we're working with for the cost growth target program. We're part of the Peterson Milbank program for sustainable healthcare costs, and they're supporting 8 states doing this work. So that's sort of our counterparts and the folks that would be most interested. And I will ask them, like, do they want to support a white paper of the process? And I think that's a great thing to ask them to get involved in. They are providing technical assistance, and that sort of white paper summation and cross-state learning is something they really want to support. Greg, Gil, Hardesh, what are your thoughts about products? And
yeah, and again, here's what I'm thinking, right? What would be something that I would see? So if you look at the affordability, right, the cost containment, it is a metric. It's affordability metric on this is the X amount of cost growth we want to see in over the years, right? It's a metric. Now, just leaving that metric alone could actually take us backwards over here, because in order to do that, we need to have some kind of metrics that would be a control metrics that would be advancing equity. So what I'm thinking is that if we can get some higher level metric, understand where we are, pick the ones that we want to see moved to what it needs to, where it needs to be, and in addition to the affordability or the cost metric, we add those metrics in, saying that we want you to do this, but we want to also focus on these key metrics that are advancing parity, and this is how we would like to see it moved. I mean, there's going to be many, but I think we're going to have to do them prioritization of where we get the biggest bang for the buck, right? If it is, I just gave an example, if it is really making sure that there is parity in having every person, based on, regardless of their race, have a physician managing their care. So for the health plan, they should be assigning everyone a physician, or so that their care can be managed well. So I think that, to me, I would see that this is the overall cost metric, but here are the parity, these health metrics that would be that we need to, also put in addition to those cost metrics that we see can be moved and has the most potential to move. And I think we have to just take those incrementally over the next 4 or 5 years or something like that.
And I'm assuming, but I'm not sure that this is really, I mean, whatever the recommendations, white paper, the products that we suggest from this group be considered, at the larger committee, and then have that there would be an opportunity to shape, what the overall product of this sustainable growth target work is moving forward. So like if we are strongly recommending that there be an equity lens on this that takes into account some of the things that Hardesh just mentioned, are that it be incorporated into you know, how the overall committee is thinking about this work moving forward. So there's room for it to be modified, right? So like those reports that we've seen thus far in terms of, you know, that isn't necessarily baked in stone, you know, that is going to be opportunity, you know, to shape ultimately what that looks like, because you know, we again, I think being proactive on this, you know, can't just be, you know, here's some good things for us to think about, you know, about health equity in this, and then just have it not be visible, you know, in how the whole thing rolls out, because otherwise it's sort of invisible and forgotten, and doesn't really have the impact of influencing the shape that this takes. So it will be interesting to see how this work does get integrated into the whole. But it seems to me that it's essential that it does, you know, otherwise we may be going forward, you know, with this overall cost containment strategy, but exacerbating, you know, the historical inequities. So.
Yeah, and I want to go back to something I think was said a few minutes ago, because I just realized that I had an assumption that probably actually should be a discussion and a deliberate decision. The comment made about bringing an equity lens to this work. I mean, I am assuming that is what we're doing. That's the whole point of this work group. We are figuring out how to bring an equity lens to this work. And so it's not, do we need an equity lens? Do we have an equity lens? It's yes, here's what it is, and here's where we apply it. Your heads are all nodding, so I'm assuming that's fair, but I wanted to check that. Like, I don't feel like equity lens, yes, no is a question at this point, but thoughts about that?
Yeah, it's not a question. It's something that's the given, right? And I'm just saying that whatever is measured is managed. And so we got to have a management, we got to be able to measure so it can be managed.
Yeah, so everything in our recommendation, white paper, whatever, is the specifics or the more concrete direction on how to bring that equity lens in.
Yeah, no, that's my understanding.
I agree, and I think the one part of nuance that I would bring to that, because I think it's starting to emerge more in the field of equity, is that equity lens is just one other tool, more of a tool, like a health equity impact assessment that gets applied sometimes at specific points in time, versus saying we're going to infuse an equity approach throughout the entire thing, and that includes, you know, kind of this proactive values around how we view this work. It does advance neutral. It includes, you know, how we work together and our agreements and norms and how we make decisions. It includes potentially equity lens tool. It includes a health equity impact assessment. Only because sometimes people will hear equity lens and they think of kind of what initially emerged was like a set of 5 questions that you answer before you make a decision. And I think what we're talking about is that plus it's, you know, how do we bake it in to all aspects? So it's not, you know, healthcare cost growth containment with equity in small font, you know, but it's really just a part of it's built into the DNA of the work we're doing. And that's just a small, I would.
No, I really appreciate that distinction, because I was not thinking about the lens as a tool. I think I was assuming equity lens equals approach infused. So let me restate. We are trying to infuse an equity approach throughout the cost growth target program and the cost containment body of work. There will be multiple tools and strategies that we would recommend.
Right. Yeah.
Okay.
Yeah. And obviously, in my terms, there are process measures that can be measured, and there is outcome measures, right? The tools are process measures.
Yeah, and I think, you know, we've got some drips of this here and there, and I think maybe this is bringing it together. So for example, last year, the program put out the impacts of healthcare costs on people in Oregon report. We had a lot of data from different sources that we put together, and some of that data was stratified by payer, you know, commercial versus Medicaid versus Medicare costs, by race, ethnicity, and other demographics. And we identified lots of disparities, and I think a lot of those data sources, a lot of those metrics could be something that we say we want to continue looking at these as the process measures that Hardesh is describing. We want to continue looking at access to care because of costs. Are folks delaying care because of costs? Are we seeing changes in medical bankruptcy? And all of those measures could be stratified, and we can continue to drive for improvement there. And I think that's a very reasonable, like, take that body of work and say, yes, we should continue doing this. It is important. Here's how we should do it. And it should be part of the cost growth target reporting going forward. Is that, Hardesh, did I sort of accurately capture what you were
Yeah.
pushing?
Yeah.
Okay. I don't want to cut us off too soon. I feel like, to me, this conversation is really sort of generating what this is, and I now want to go put it all on paper. And then we can have more conversations about what that is and like the details and dig into certain sections. But I don't want to cut anybody off too soon. Other thoughts, high level directions. Maria, if you're listening and still around, do you have any reflections or thoughts for us having heard this conversation?
No, I am delighted to hear the conversation. I think it's super interesting. I can't help but thinking that, you know, just going upstream and figuring out how the systems we have set up are not allowing us to do growth target with an equity framework, you know, and that's one thing. And then the other thing that comes to mind is, how are we going to measure success? You know, we don't even have a health equity measure or health equity sensitive measures that are real measures, outcomes measures, and not process measures like the one that we have. And are those two things together eventually? Is it necessary that we also overhaul the metrics system that we have in order to be able to truly reflect if we are actually moving the needle in equity? Because we don't have that. I mean, Michael is witness of all our efforts on trying to develop a health equity measure years ago. And then every measure we try to develop ran against a criteria developed by all the powers that be at the federal government that do not have any room for equity either. So even if we try, we run against it. So this is a great conversation. I didn't want to intervene. I'm just here to listen as a part of the, I am the lead staff for the Health Equity Committee with my colleague, Alex Friedman, who couldn't join. But we want to be listening to these conversations and see all the ways that we can support this work and where the committee can also be part of. So thank you so very much for your willingness to talk about these issues. And yeah, this has been great. I've been paying very close attention to it.
Maria, I definitely want to ask you for help as we start putting this together and, you know, thinking about logic models and all of that. So thank you.
Sarah, one thing that these comments kind of triggered for me is, you know, and of course, mostly familiar with the Medicaid space, you know, with the CCOs, and there's been a lot of effort to focus on quality metrics, and that's been good. You know, that's I think helped advance a lot of good work over the years, but it's been sort of siloed from thinking about equity or thinking about costs, although costs have been in the background, you know, because there's this 3.4%, you know, target. And it seems like what we're trying to do is integrate, you know, these silos where, you know, we can't just think of quality on its own without that equity lens and without costs too. So that kind of triple aim or quintuple aim, needs to come together in some way so that, this cost growth target group, at least initially from what I saw, didn't really have equity as a consideration as part of it, but fortunately, we've got this group now to create this equity approach. And we're also talking about how do you measure that, going forward? What are the process measures? What are outcome measures? Which in my mind, when we're talking about health, suggest, health outcome, health quality. So how do we bring all those things?
Yeah. And Gil, I definitely want to recognize what you're saying, and that this is all they have been siloed conversations, and we're trying to nudge them closer together. And also, I want us to be really careful about scope, because as we've said, as Maria referenced, I mean, we've been thinking about how to do this and what is a health equity measure for years and years and years. And I do not want us as the cost and equity work group to say that we're going to solve that in the next 2 months. I want to put a little bit of a parameter around that. So I think for me, maybe this is the conversation of how do we define success? And if we say, as part of the cost growth target program and our cost containment initiatives, we think it's really important to monitor these 4 things related to affordability and disparities and some of the root causes that we might identify. That to me is different than saying we have an equity measure and we're going to create something new. So I just want to be really careful about the lines, because as soon as you start talking about developing measures, there are a number of groups, and some of you are plugged into those places where those conversations are happening, and it's really complicated, and I don't want us to get into that in a way that we can't necessarily solve. So sorry, I feel like I'm being like, no, absolutely not. But I think, yes, it's connected, and yes, we want to break down those silos. And also, I don't want to get, there are other groups that are thinking about health equity measurement, especially on the Medicaid side. There's a whole new proposal as part of the 1115 waiver to do the measurement work differently. And so I think we can learn from that, and anything that group is developing that is applicable, we should pull it through and use it as part of the monitoring. But I don't think we can fully collapse those silos, and I just want us to be really careful about that. So hopefully that makes sense, and I'm not trying to shut that body of work down, but I think this is more of a how do we define success and say these are things that would be important to monitor if we know that there's a disparity in, again, delaying access to care because of costs. Maybe our definition of success is we want to see that change. We want to see that disparity go away. That's not the same thing as we're going to create a new affordability equity measure that will rule them all. Sorry, I'm
Yeah. No, sorry, I didn't mean to open a can of worms, and my comment was actually to exemplify one of the issues where the system, they measure things, which may or may not have anything to do with this, but the measure system and the criteria and the processes are also part of this awakening of putting equity in front of these things and say, well, what we have been doing in the past doesn't really work for everyone and doesn't represent the real picture. And how do we go back and try to mend systems or erase system completely, bulldoze them, and then rebuild? So I guess that my intent with that comment was just to say that this is not the only part where we are pioneering, we are trailblazers, if you will, on this. We have no other people to look but actually ourselves in this work. So you should give yourselves a pat in the back, because even though there is no framework for us to follow, I think this conversation today was very useful, because you were actually really covering pretty much all the things that I can think of that are critical to be covered. So yeah, my apologies for opening that kind of word. That was not my intent.
Okay. Shall we talk about next steps for a minute? Are we ready to move there? Any other comments or questions or reflections? I don't want to cut us off too soon. Okay, next steps. Here's what I heard. We should start putting this on paper because we are visual and would like something to be able to react to. It's always more helpful to have something to react to than this just open discussion. I will start that. I will get something on paper and send it around over email. And I would love it if we could do some iterating or have some reactions and discussion over email before we have our next meeting. I see heads nodding. Is that okay? Okay. I'm going to try to create some structure for the discussion, and I'm going to recognize upfront that this is possibly artificial structure. Like, this is all related, it's all interrelated, and we're not going to try to pretend it's not, but for the purpose of having conversations and identifying strategies and tools, we might chunk it out just to keep some distinction, even though, of course, it's more complex than that. I also heard that we should follow up to see if any consultants or our partners would be interested, and if we have resources to essentially do a white paper of the process, that case study. So I will reach out and get that conversation going. Are there any other specific next steps, or do any of you want to volunteer to put some of this on paper or to help move some of this forward, or do you want to wait until I start that and then react?
I like the latter.
Yeah, the only thing I would add to your kind of next steps, which is I think part of that framework or approach that you were gonna try to draft up, is really honing in on that, one of those key questions or conversations around how does health equity and cost growth containment, fit together or not, big picture, which it will, help us flush out that framework or the visual that you're creating even more, just to kind of lift that up. And then, yeah, I will gladly help react to stuff, but don't have capacity to probably do the other part, development.
Okay, I can happily put some stuff on paper. It will probably have a lot of things wrong with it, or things that you have strong feelings about and want to rearrange, and that's great. So I will try to get that out. I'll try to get something out by the end of next week for initial reactions. And then we'll have Gerondi reach out and find time for another meeting. I'd like to meet again later in April. Does that all sound okay?
I do have a question around what, if anything, we want to do for any folks who are on this work group that weren't able to make it. I feel like this was a pretty pivotal conversation for our group and our group process and what we're trying to achieve. And so just to help bring those folks up to speed, I don't know if that's something that Sarah, you all can take on as a part of your role, or if that's too much, or if we as members of this work group need to take on some of that.
Well, let's think about that. So we are recording. We'll post the recording. That'll be available probably tomorrow. I was taking some notes. I can clean those up and send them out in the next day or two as well. So who are we missing? We're missing Karis, right?
Is that it?
I think that might be it.
Okay.
So we can make sure that she gets the recording and the notes, and then maybe make available if she would like to check in with me or any one of you. Would you be willing to possibly chat with her if she has questions?
Yeah, I think that's a great idea.
Okay, I'll make sure she gets that. Okay, anything else for today? I agree, this was pivotal. It feels like we have suddenly a lot more of a what. There's now a what there. So I'm looking forward to now starting to build out some of these pieces and talk about what some of this means within that framework. All right, thank you so much for your time. This has been great. I really appreciate it. Email me if you have any thoughts or questions or anything else offline. Happy to incorporate that. Any final comments or thoughts from anybody?
That's exciting work, it's really great. I think and again, planning to have this conversation with the folks back at this Margolis Center, and I'll send that invitation out, if there's others that want to join.
Great. All right, thank you so much, everybody. Look for email from me coming soon with some things to react to, and we'll also get another meeting on the calendar for the end of April. Have a great rest of your week.
Thank you.
Thank you.
Great, thanks all. Bye.